Good evening, everyone. Redcliffe Genetics welcomes you all to today's webinar session on Wilson disease, the problem, the test, and the solution. Today, we have two eminent doctors from the medical fraternity, Dr. Nida Mirza and Dr. Veronica Arora. Dr. Nida Mirza is an MBBS, MD Pediatrics, a senior resident from MAMC New Delhi, and FNB Pediatric Gastroenterology at Indraprasth Apollo Hospital, New Delhi. She is a faculty in the Division of Pediatric Gastroenterology, Department of Pediatrics, SAMES, and also a visiting consultant at the Apollo Hospital, Indore. Dr. Nida is also a recipient of Healthcare Award by Golden Aim Society and has several articles and book chapters published in her name. Dr. Veronica is Associate Consultant and Assistant Professor at the Institute of Medical Genetics and Genomics, Sir Gangaram Hospital. She is an MBBS, MS, Obs Gynae DNB, and Super Specialty Medical Geneticist at MNAMS. She's an executive member of Delhi SFM. She's an executive member of Delhi SFM and also a DNB gold medalist with more than 55 in peer-reviewed journal publications and has achieved several awards. Dr. Veronica, I now request you to introduce the respected chairperson of today's webinar, Dr. Anil Arora.
Thank you so much, Redcliffe Genetics, to give us this opportunity to discuss this very important and common treatable disorder called Wilson disease. So it is my pleasure to welcome today someone who really does not need any introduction, Dr. Anil Arora, who is one of the most eminent gastroenterologists in India. He is the chairperson and head of the Department of Gastroenterology at Sir Gangaram Hospital, New Delhi. He's done his MBBS, MD, and DM all from All India Institute of Medical Genetics and has several awards and credentials to his name. He has an experience of more than 30 years in treating these disorders, and it is often said that most of the patients who are diagnosed with Wilson has seen him once or the other time. Thank you so much, sir, for taking out time from your super busy schedule and gracing this occasion. So without further ado, we can now start with Dr. Nida's talk. And before that, I would just like, sir, to speak a few words about your experience and journey with Wilson's disease and patients.
Thank you, Veronica, and thank you, Nidan and the organizing team for having given me this opportunity to interact with you. In fact, in hepatology practice, more often than not, you are stuck up with diseases which are neither treatable nor preventable. So here is a disease which can be easily prevented and easily treated, provided you get on to the root cause of the problem right at the time of its inception, maybe in pregnancy and subsequently in the early childhood. Problem is, as physicians, as gastroenterologists, as hepatologists, or as general practitioners of the medicine, we tend to underestimate its prevalence. And that is the reason by the time patient comes to you, patient does have a frank florid manifestation involving liver and or the neurological symptoms. So this is, in fact, exhilarating to know that is one of the most treatable and preventable diseases in hepatology. Now, if you try to nip the problem in the bud by diagnosing it right in the infancy or in the early childhood by screening or the contacts, I think you will be doing a yeoman's job. If you look at the florid practice in hepatology, hepatitis C has become treatable, but other diseases like alcohol, non-alcoholic fatty liver disease, and hepatitis B, you have to live with them lifelong. This is something, if you try to handle it right at the time of its presentation, I think you will do a good job. I am glad that this young brigade is taking good initiative to come out with the nuances of treating, preventing, and diagnosing Wilson disease. So back to the organizers.
Thank you. So we have a question here, sir. We'll just take this. So the question, sir, can we have your video and audio, please? Yeah, so the question is that I hope you can see it on the question answer. Is there any permanent cure? Patient is having low platelet count since 1 year. The patient is 16 years old, currently on trientine, 2 capsule daily with one D pen daily as well. So maybe he's receiving both. Surjit Sarkar is the, so spleen is also increased, and they are not experiencing much changes on these medicines. So Surjit, one question before the answer: is this diagnosed to be Wilson's? Is this condition? And sir, would you like to answer this question? Is
Yeah,
the is a
I think it's a very relevant question. If you have history of thrombocytopenia, if you have a splenomegaly, that means you have a long-standing deposition of the copper into the liver, producing something called cirrhosis and subsequent portal hypertension, which is a trailblazer. Now, at every point of time, unless you have a very severe advanced liver disease, Wilson's disease will continue to be treatable, because if you understand the basis of the problem, which is going to be very elegantly presented by Veronica and Nidan, that this is a basic metabolic defect which lies in the genes. You cannot undo the genes, you cannot undo the nature. But what you can do is try to undo the downstream changes which are occurring because of the alteration of the gene and resultant changes in the enzymatic metabolism. So at every point of time, the disease, you should not say that it is not treatable unless you have an advanced liver failure or extensive degenerative changes in the brain. Short of that, just splenomegaly and presence of thrombocytopenia only gives you a clue that you have to be aggressive in therapy. So at all points of time, it remains treatable.
So he's asking for a cure. Do you suggest liver transplantation as a cure?
Yes. See, we will have to give a good judicious combination of the drugs, which include either D-penicillamine, trientine, or else zinc, and see how much of the copper can be chelated. You should understand these drugs are not going to undo the damage which has occurred in the liver, but they can prevent the ongoing damage because of the continuous deposition of the copper, which will incite inflammation within the liver. Now, if you have been able to get rid of the copper both from the liver as well as the body tissue, and there are wherewithals of knowing where the copper is depositing and in what extent, then residual damage, if it is extensive, will require liver transplantation. But if you have been able to diagnose it early in the absence of liver cell failure, now splenomegaly and thrombocytopenia does not mean you have an advanced disease. It just only shows portal hypertension, and still we should be able to do a good job by controlling it.
Okay. Thank you. And there is another question. And that good evening, sir and team. Is liver regenerative? That's the question.
Liver has an extensive power to regenerate. In fact, if you hear the Greek mythology stories, then there was one owl which will come and eat away the liver of an individual who was being prosecuted because of the blasphemy in those days in Greek mythology. And every other night his liver will generate. Liver has a huge potential to regenerate, provided there is no injury in the remnant liver. Now, in a Wilson's disease state, the whole liver or all the hepatocytes or the liver cells, which are the basic framework of the liver, they tend to get equally affected. So if you take half of my liver and transplant it in any of normal person, my rest liver will regenerate because the remaining liver is normal. Whereas in conditions like Wilson's disease, the whole of the liver is equally affected. So the regenerative capacity of Wilson's disease liver cannot be compared to a normal liver. That is the reason we have a very blossoming LDLT program, that is living donor liver transplantation program, in which you take half of the liver from a recipient and put it to the donor. And within the donor's liver regenerates within a period of 2 weeks. So that big is the regenerative capacity, provided the remnant liver in the donor continues to have the normal parenchymal function.
Okay. So the next question is that is there any diet or any molecule which can be helpful to regenerate the liver?
In fact, if you look at the composition of the liver has been given to us by the nature God, and it does not need anything to regenerate. What it needs is avoidance of the toxic substances which damage it, like alcohol, like painkillers, like hepatitis B virus, like overeating, like deposition of the fat in the liver. Given the choice, it is a faithful servant, it is an obedient servant, which does not require any maintenance, does not require any medication, doesn't require anything to regenerate. But we make unnecessary damage to it by hooking on to the drugs, by taking unnecessary medication, by drinking excessive amount of alcohol, by not exercising, by putting on our weight, and in the bargain, we end up depositing huge amount of the liver, fat in the liver, which with passage of time tends to incite inflammation, resulting in fibrosis and cirrhosis. So it doesn't need any regenerative capacity, but what it needs is a respect, love and care and affection. That simple, tender love and care is more than enough for liver. You don't need any medication for that.
Okay, so thank you, sir. Now another question from Priya Arora is that my son has been on trientine and zinc for 5 years. Urine copper is below limit. Still, his liver enzymes remain high. What can I do?
Yeah, no. Now another way of looking at it is whether you have been able to chelate the copper from the serum. If the copper in the serum has also been chelated, maybe you will have to tone down the dose of trientine and zinc. And once there is an inflammation in the liver, then you can give hepatoprotective drugs. Like you have drug like S-adenomythiosin, you have antioxidants, or you have drugs which will decrease the inflammation. So once you have been able to chelate the iron, you may have to look for other causes of persistent elevation of enzymes. There may be concomitant viral infection, there may be other drugs which may be causing hepatotoxicity, or there may be deposition of the fat, which certainly need differential treatment depending upon the cause. Once you have been able to chelate the copper both from the liver as well as from the blood and the urine, you may have to taper down the trientine and zinc therapy.
Okay, so we can add N-acetylcysteine as well. That may help in bringing.
It is an antioxidant. Once you have, it is a scavenging agent. It will try to take away all the reactive oxygen species and free radicals, which in any case, these are the general non-specific parameters which have a propensity to keep on disturbing the endoplasmic reticulum and mitochondrial stability. And the more antioxidants you have, the better it is.
Okay. So now there is another question that are the neurological symptoms reversed after transplantation?
In fact, there is an excellent publication from France for the first time. Generally, it was believed that once you have a cerebellar degeneration, you will not be able to come out of it. For the first time in hepatology, there was a publication of 20 cases in France in which they, after having a definitive, objective, and confirmed cerebellar degeneration, these patients had a remarkable recovery, so that they were able to get back to their normal life routine without working in the offices. So from a state, totally dilapidated state in which you are dependent on day-to-day activities on your relatives, to a stage where you'll be able to do self-care, is a big advance which has been achieved by recent transplantation. Mind you, you cannot be as normal as we are without any Wilson disease, but there is enough recovery after transplantation. But that study has been conducted only in France, that we need more validation of these types of results. We want the same types of procedures, and the experimentation should be reduplicated in other centers of the world. But that was some ray of hope.
So thank you. Now the next question is, I think we'll just take this and then we can just proceed. 2 more questions maybe. I am Jaskaran, 32-year-old neurological Wilson's disease patient. I was on food pipe for 2 years. Over the last 3 years, I have been doing swallowing and speech exercises. Speech has improved drastically, whereas swallowing has not. I still have to push myself and take liquid to drown it. So I feel hungry after half an hour because I cannot fully feed myself. How can you help me?
Yeah, now the problem is, because of the deposition of the copper in your brain, all those neuronal endings which bring the afferent stimuli, that means they bring the orders from the brain down to your food pipe to contract and push the food bolus down, they're getting weakened. So in a situation like this, if you try to take prokinetic drugs, that means drugs which will increase the motility of the food pipe, drugs like, you have drugs like prokinetic agent like domperidone will help you. You have drugs like perinom, that is the metoclopramide or or drugs which act throughout the GI tract. These are the drugs like ecoshiamide. They are known to be increasing your gut motility downwards into the caudal region. So you can try ecoshiamide, you can try domperidone and metoclopramide. That may be of help.
So another question is that as the trientine works, then copper will be released. At any point of time, can the liver copper become almost normal? Is that possible?
Yes, you see, the problem is, after all, if you look at the copper metabolism, copper is not there to give you the disease. It is a normal physiological process which gives you the day-to-day activity. You cannot live normally without the presence of the copper. The only problem with Wilson disease is the copper is not being incorporated into the ceruloplasmin. So you have a lot of free copper. And daily, whatever you eat, whatever metabolism is going in the body, you are copper. You cannot go away from that. So even if you have nil copper in the diet, there will be intrinsic mechanisms in the body which will keep on producing copper. So that is the reason, even if your copper from the blood has gone away, from the urine it has gone away, a simple tablet like zinc will only prevent the absorption of the copper on the GI tract. But because of the fact that any metabolic activity occurring in the areas of the body other than the liver will tend to push the copper back into the liver, because it is a component of so many enzymatic processes. So you will need some sort of chelating agent which will not let the copper accumulate within the liver. So you will require a longer therapy even if the serum copper is down.
Okay. So now the question I think that I could answer is about genetic testing, that the lipid score is 3 and urine 24-hour coppers is more than 100. Should mutation analysis be done? So the answer is yes. It is confirmatory, maybe a better way to confirm than a liver biopsy. And what is the sensitivity and false negative rate of currently? So sensitivity, genetic testing is not where we talk about sensitivity, because we need to find the mutation. So we do find a mutation in 70% of the cases. Where we don't, it is a genetically negative Wilson's, but it does not mean that the mutation does not exist. With the currently available technologies, we can only pick up mutation in about 70% of the cases. Another question is that can we do a prenatal diagnosis in the next pregnancy? So the answer is absolutely yes. We can do a prenatal diagnosis. We can test the pregnancy, the fetus in the next pregnancy, to prevent the recurrence of the disorder in the next pregnancy. The prenatal diagnosis is ideally done around 11 weeks of pregnancy by a procedure called chorionic villus sampling, where we take a sample of the placenta and test the placenta for the presence or absence of Wilson's disease related mutations, and tell the family that the fetus is affected or unaffected. So that's how we can do a prenatal diagnosis and help the family. So with this, we have answered a lot of questions. There are 2 or 3 questions in another language, which unfortunately I'm not able to interpret. Maybe Sahil can help us in that later. And we will move on and now come back to the questions after the talks. Is that okay? Can we proceed now?
Yeah, we can go ahead with the presentations.
Thank you. So Dr. Nida, I welcome you for your presentation. Dr. Nida, will you share your screen now?
Yeah, I am audible.
Yes.
Okay, so myself, Dr. Nida, I will be presenting only a basic knowledge overview of Wilson's disease. What is Wilson's disease? How it happens? What are the complications? And how it is diagnosed? And what is the treatment available? So, as per the demand of some of the participants, I have made some slides in Hindi so that they can understand better. Yeah. So we are going for basics of Wilson's disease. So क्या है Wilson disease? Wilson is a disease in which copper is increased. So basically it is a disorder of copper metabolism, but you can say copper is content is increased in the some of the tissues. So liver में problem होती है, brain में problem होती है, and other organs. क्यों होता है? It is a condition which copper is causing toxicity to body. जनरली क्या होता है कि कॉपर हमारी बॉडी के लिए रिक्वायरमेंट है. अगर हम कॉपर नहीं लेंगे तो हमारी को बॉडी को एनीमिया होगा, बहुत सारी प्रॉब्लम्स होंगी. सो ये प्रॉब्लम होती है. अब ये क्यों होती है? क्योंकि ये एक जेनेटिक म्यूटेशन के कारण होती है, और दोनों म्यूटेशन मदर फादर दोनों में से एक एक आता है, तब ये होता है. प्रॉब्लम क्या होती है? प्रॉब्लम ये होती है जनरली हमारा जो भी एक्सेस कॉपर होता है वो हमारे यूरिन के थ्रू एक्सक्रिएट हो जाता है, लेकिन किसी इस प्रॉब्लम में क्या होता है कि इट इज़ नॉट गेटिंग एक्सक्रिएटेड, बल्कि ये क्या होता है हमारे लीवर में और ब्रेन में डिपॉजिट होने लग जाता है, जिससे वो उनको खराब करता है. सो व्हाट इज विल्सन्स डिसीज बेसिकली? विल्सन्स के दो जनरल कॉमन प्रेजेंटेशंस होते हैं. हेपेटिक प्रेजेंटेशन जो लीवर की प्रॉब्लम्स होती हैं, और सेकंड प्रेजेंटेशन इज न्यूरोलॉजिकल. सो हेपेटिक प्रेजेंटेशन जो होता है वो जनरली 12 साल से कम उम्र के बच्चों में होता है. वो प्रेजेंट करते हैं हमारे पास हेपेटाइटिस, जैसे जॉन्डिस लेके, नॉर्मल जॉन्डिस लेके, या फिर एनीमिया लेके. समटाइम्स सिर्फ एक एनीमिया प्रेजेंटेशन होता है और कुछ नहीं. न्यूरोलॉजिकल प्रेजेंटेशन 12 साल के बाद होता है जनरली, जिसमें स्पीच की प्रॉब्लम होती है, हाथ पैर बिल्कुल हिलते रहते हैं और प्रॉपरली कुछ कर नहीं पाते हैं काम, और हाथ पैर अकड़े हुए कड़क टाइप के हो सकते हैं. वह क्लिनिकल फीचर सबसे पहले हम लीवर के पॉइंट ऑफ व्यू से देखेंगे तो जो जॉन्डिस होता है उसको एक्यूट हेपेटाइटिस बोलते हैं. एक्यूट लीवर फेलियर होता है, जिसमें हमारा जो बॉडी का जो खून जमाने की क्षमता होती है वो भी खत्म हो जाती है. द आईएनआर विल बी मोर देन 2, द चाइल्ड विल बिकम एन्सेफेलोपैथिक, कोमाटोज. प्रीवियस एपिसोड्स हो सकते हैं जॉन्डिस के और एनीमिया के. इसके साथ में जब एक्यूट प्रेजेंटेशन होता है विल्सन, व्हेन देयर इज एक्यूट प्रेजेंटेशन ऑफ विल्सन्स डिसीज, देन देयर कैन बी ए किडनी फेलियर आल्सो, एंड लेट स्टेजेस में दे प्रेजेंट एज सिरोसिस. Chronic presentation sometimes क्या होता है, they don't get diagnosed at early stage, they get diagnosed only when there is chronic hepatitis leading to cirrhosis. So इसमें sometimes it is get confused with autoimmune hepatitis, but that can be presentation. न्यूरोलॉजिकल विल्सन, न्यूरोलॉजिकल और साइकेट्रिक प्रेजेंटेशंस. ऑनसेट एक्यूट और क्रॉनिक होते हैं. वेरिएबल होती है एज ऑफ ऑनसेट, स्पीड ऑफ प्रोग्रेशन. इट डिपेंड्स पर्सन टू पर्सन, किसमें एज ऑफ ऑनसेट ज़्यादा है, किसमें स्पीड ऑफ प्रोग्रेशन कम है. डिटोरिएशन होने लग जाता है स्कूल परफॉर्मेंस का, दैट इज कैन बी डायग्नोज्ड इन अर्ली एडोलेसेंट्स. मास्क लाइक फिशीज हो जाती है, फेस एकदम मास्क जैसा लगता है, रिजिड बॉडी होती है और गेट इम्प्रॉपर हो जाता है. दे कैन हैव दिस लाइक पार्किंसंस लाइक डिसऑर्डर्स व्हिच हैपेंस इन ओल्ड एज, एंड दे आल्सो हैव ब्रेडिकाइनेसिया, ट्रेमर्स एंड डिस्काइनेटिया. साइकेट्रिक विल्सन्स डिसीज जो कि बहुत अनकॉमन है, लेकिन इट शुड बी सस्पेक्टेड वेन एवर एडोलोसेंट प्रेजेंट विथ साइकेट्रिक फीचर्स. सो दे कैन हैव डिप्रेशन, न्यूरोटिक बिहेवियर्स, फोबियाज, कंपल्सिव डिसऑर्डर्स, एग्रेशन, कॉग्निटिव डिटोरिएशन, वर्सनिंग स्कूल परफॉर्मेंस, पुअर मेमोरी, एक्सेट्रा. स्केलेटल मैनिफेस्टेशंस हो सकते हैं. आर्थराइटिस कैन बी ए प्रेजेंटेशन. रिकेट्स, हड्डियों की प्रॉब्लम हो सकती है, हड्डियों में दर्द हो सकता है. स्केलेटल कॉम्प्लिकेशन कैन ऑल्सो बी देयर. रेनल कॉम्प्लिकेशंस भी विल्सन्स में कॉमनली होती है. दिस आर रेनल ट्यूबुलर कॉम्प्लिकेशन विच कैन कॉज लॉस ऑफ एमिनो एसिड्स एंड ग्लूकोज इन द यूरिन विच ड्यू टू impaired phosphate absorption. So how the diagnosis of Wilson's disease is made? KF ring can be done, which can be done on slit lamp examination, but less than 10 year में KF ring possibility कम होती है. Only 50% they can get positive. Family history हो सकती है कि किसी सिबलिंग की डेथ हुई हो सेम प्रॉब्लम से, या फिर जैसे कि किसी सिबलिंग को साइकेट्रिक फीचर हैं और नेक्स्ट सिबलिंग को हेपेटिक फीचर्स हैं, या फिर फैमिली हिस्ट्री ऑफ कॉन्सेग्निटी, कजिन्स में जो मैरिज होती है. स्लर्ड और स्लो स्पीच, jaundice can be presentation in hemolysis, low anemia. So this is a proper unexplained liver disease है. इसमें how we will go for this. Basically this is for doctors how they go, but we have to see at least two of the things should be there. KF ring, ceruloplasmin should be low, and 24-hour upper cup should be more. This is a liver biopsy specimen. You can see here, it will shows fatty liver. And the problem with Wilson is the liver biopsy will give only a patchy appearance. So the copper deposition is only patchy. So sometimes in liver biopsy, the amount of copper may be low and Wilson disease may be present. So there is an only non-specific findings of liver Wilson disease in liver biopsy. Only fatty liver is seen. You can see in MRI the deposition of copper here is causing a hyperintensive lesions. So diagnosis is made on low serum copper and ceruloplasmin. Serum copper should be low. So this is the main confusion. What they say is we have low serum copper. So how we can have Wilson disease? See, copper is getting deposited in solid organs. So this is serum copper will be low. Urinary copper will be more than 50 microgram per 24 hour. When we give penicillamine and then test urinary copper, the copper level will increase. Hepatic copper on liver biopsy will be increased, and the alkaline phosphatase will be low. The mutation will be ATP7B mutations. Differential diagnosis can be all other types of hepatitis. Usually in children, autoimmune liver disease is the most common differential diagnosis of the Wilson's disease. Treatment consists of penicillamine, which is a main chelator therapy available. However, the other therapies available are zinc, triantine, and tetramethyl is now obsolete. Problem with penicillamine is it causes worsening of neurological features in some cases, but it is a mainstay of treatment and it is a cheaper drug. Triantine is a costly drug with less neurological side effect, but in hepatic Wilson, I say that penicillamine works very good, and zinc should be taken by all children specifically, because we can't restrict the particular diet of them which causes the Wilson's disease. However, if a late stage is present, we can go for transplantation, and the most important stage is family screening, because Wilson's commonly happens in family. Okay, thank you. Hi, Dr. Veronica.
Thank you so much, Dr. Nida.
Yeah.
So, thank you for an elaborate discussion on Wilson's disease. And if there are any questions, you can take now.
Yeah. There is a question. I think Dr. Veronica, it will go for better for you. Can we diagnose Wilson carrier too?
I'm just having some problem in Zoom. Till then, maybe you can discuss. And
Okay. Okay, so can we diagnose Wilson carrier 2 is a question. So yes, we can easily diagnose Wilson carrier if the Wilson disease patient is having genetic test done. So we can just go for a simple Sanger sequencing of the same gene, and that cost also very less than the genetic test of the main patient, and we can easily diagnose Wilson carrier. And it is I think every family member of this Wilson disease should go for Wilson carrier testing, because when they get married, they have a risk of getting a baby with Wilson disease.
okay, just 1 second.
Current status of gene therapy. See, gene therapy is only in the trial stage. So it is not, if we can't say that it is effective for now. Maybe after a few years, but for now there is no treatment by gene therapy. Anybody have any more questions? There's one more question. Is the Trantine work the couple will be released at any point of time? Liver may become almost normal. Is that possible? It depends on your stage when you're diagnosed. So most the early you are diagnosed, and the more the chances of having a normal liver.
Is my screen visible now?
Yes, it is.
Yes.
All right. So we have discussed about the epidemiology and the pathophysiology, some clinical features. And so I think there was a question. So basically, the agenda of this program really was to answer questions. So about gene therapy, as Dr. Nida has said, just me being a geneticist, I would like to add that now we have some trials that are going on. So those of you who are interested in being part of the trials, maybe you can get in touch with me and I can give you more information about that trials and you can try and be a part of it. It is, that being said, it is not very easy to become part of trials that are not placed and based in your own countries. And about a therapy that is cost effective, definitely the answer is that it depends on the stage of the Wilson's disease you are in. If you're diagnosed right in time, the best therapy to do is your penicillamine and trientine. Penicillamine works very well. I have seen very few people who prefer trientine really over penicillamine. So now my job here is to discuss, teach you a little about why does this disease happen? What did we do wrong that we suffered from this disease? How can we prevent this disease to go to another to our children? And how severe is the disease? Can we get to know? And is everything related to Wilson's really genetic in origin? So is it really a rare disease? As in India, policy of rare disease has its no mention. So the thing is, we know about rare diseases, it is not like there is no mention. They Wilson's is a metabolic disorder, and in your rare diseases there is a group of rare diseases which concentrates on metabolic disorders. So, because the treatment of Wilson is not so expensive, there is no provision for it, right? For it, which is available in the rare disease policy. But definitely, it is a rare disease because it is caused due to some alterations in the ATP7 genes. So, now the first thing to know is that it is caused by mutations or problems or some variations in the ATP7B gene. So we all carry two copies of ATP7B gene, and a person will have
Veronica,
Wilson's disease.
not moving.
Yeah, that's okay. I'm not trying to move the slide.
Okay.
So a person will have Wilson's disease only if both the copies of that gene, of the ATP7 genes, would be mutated. That is, both the copies of the ATP7 genes, when they are not working, that's when the person will have Wilson's disease. So each one of us will have two copies of ATP7B gene. One we will receive from the father and one we will receive from our mother. So both of our father and mother must be carriers of these disorders. That's the only way we can have a disorder called Wilson's disease. So it is not something that we can change, and it is not something that we can already check for before the occurrence of a first child. So if you are a person who's suffering from Wilson's disease, we can 100% make sure your child does not have Wilson's. If you are a sibling and you want, if you are a parent and one of your child has Wilson's disease, we can make sure that your next child does not have Wilson's by testing that child in pregnancy. So okay, so about this treatment that you mean that 18,000 per month is a costly affair, I definitely agree with you. And I think that if we put this up for the rare disease program, we can get this for sure. Also, we know like trientine is not the only drug. Penicillamine works as well. So maybe that is another option for people who cannot afford that as well. But definitely it's a rare disease, and for rare disease, everyone who's suffering from a rare disease can get that 20 lakh amount from the government to help them in therapy. So now just viewing the slides a little, my basic message, what I wanted to tell, it has, I hope, reached all of you, that so what role has genome sequencing in playing in Wilson's disease? So now the different types of genetic tests I would discuss, but I don't know how much is it's within the scope of this webinar. So if you are having Wilson's disease, we have to sequence, and we have to sequence the ATP7B gene. Now, the ATP7B gene can be sequenced by Sanger sequencing, which is the best method. It can be sequenced by and that will cost around 30,000. It can be sequenced by exome sequencing and genome sequencing. Genome sequencing we do not have to do. We only have to do genome sequencing when we don't know what disorder we are looking for. So for your ATP, for your Wilson's disease, if you know you're suffering from Wilson's disease, then the test of choice is Sanger sequencing. It is not genome sequencing, right? And do not spend unnecessary money. And the test of choice you need to do is Sanger sequencing. So now the epidemiology. So this is the answer to your question. The epidemiology is this: 1 in 30,000 live births have Wilson's in most of the population. Men and women are equally affected. So coming to the genetics of Wilson's disease, which is caused by mutations in the gene which code for ATPase, copper transporting beta polypeptide, as we can see here, which is located on chromosome number 13. It is a relatively large gene, and it is composed of 21 exons. Now, in Sanger sequencing, we have to sequence each exon separately, and that's why the cost of this test is around 35,000. So different types of defects have been identified in this ATP7B genes, and over 300 mutations have been identified. So we have to sequence the whole gene, only then we can know which mutation is present. Once we know which mutation is present, then we can do a prenatal diagnosis or a cascade screening, like look for different family members. So also, depending on the type of mutation, we will know the severity of Wilson's disease, like what will be the amount of copper that will be deposited, or will the brain be more involved than the liver, and so on. So it depends also on the nature of the mutations. So the frameshift deletions and nonsense mutation that cause the protein to not form usually result in a more severe form of the disorder than mutations which are milder. So in most ethnic groups, either one or a small number of these ATP7B mutations are prevalent, in addition to many other rare mutations. This is one mutation which is one of the most common mutations with an allele frequency of 10 to 40%. That is that I don't know how many of you have your reports in front of you, but at least some of you would have this mutation because it's a common mutation. So compound heterozygous mutations for ATP7G mutations are frequent in Wilson's disease, which makes the genotype-phenotype correlation challenging. That means that, so compound heterozygous means that there are two different mutations present on the two different copies of the ATP7B gene, and each mutation will implicate a different involvement. For example, if one mutation is mild and one is severe, then it would be a moderate sort of a Wilson. So that's sort of a genotype-phenotype correlation. That is that the genetic makeup will decide the type of Wilson's one person is going to have. So now we come on to the pathology of the pathophysiology of Wilson's disease. So as we know that if there is increased copper, there would be increased intestinal absorption of copper. And when there is plasma albumin binding that is present, there are two types of disorders that can result. One is the Menkes disease. And when there is a problem here at the ATPase channel, that's when we will have Wilson's disease, that that is present here. Another disorder that is caused due to copper metabolism is aceruloplasminemia, where there is deposition of iron in addition to copper. So in Wilson's, we know there is increase in the urine copper, there is increase in the free serum copper that is present, and the bound copper is decreased. So this is the how the Wilson's disease will progress. Now someone asked about genetic mutations and where the genetic defect lies, and in how many percent of the cases will we find these mutations. So the answer is we will find these mutations in about 70% of the cases of Wilson's disease. So the Wilson's disease, as we know, will affect the liver, but it will also affect the bone. It will cause anemia. It will cause some problems in the central nervous system, in the heart, and also in the kidney. There is involvement of the kidney in the form of proximal renal tubular dysfunction. So if you're suffering from Wilson's disease, these are the organs that we have to screen for regularly in all of you. And but one thing to remember is that every person's Wilson's will not have affection of all of these organs. It will depend on the type of mutation and the type of accumulation, on the extent of accumulation of copper, which organ is more involved than the other. And the commonest organs to be involved are the liver and the brain. It is more common that in the Wilson that is present in children, the liver is more involved, and when the presentation is in adulthood, the brain is more involved. So we have discussed about some basic clinical features, and if there are any questions about the clinical features or the genetics of Wilson's disease, we can take them now, or we can now proceed to the hepatic Wilson's disease, in which we know that the KF rings are visible in 50% of the patients with hepatic disease, and the hepatic disease is seen in all forms of liver involvement. There can also be an asymptomatic disease. There can be abdominal pain, jaundice, your liver can be enlarged, your spleen can be enlarged, there can be ascites, there can be upper GI bleeding, and someone mentioned about splenomegaly as well due to portal hypertension. There can be peripheral stigma of chronic liver disease and cirrhosis, which have to be looked at, and the mental status changes can also be present. So the hepatic Wilson's can present in all these from asymptomatic to jaundice to hepatosplenomegaly can be present. So children initially present with liver disease. So we know that so L comes before N, right? So when there is a child, and so someone also asked that a parent has Wilson's disease. Should the parents be alert about Wilson? What all should the parents be alert about? So Dr. Nida or Dr. Arora, would you like to answer this question? Dr. Nida, would you like to take this question? Yeah.
Which question? Parents should be alerted. Okay. I think he's asking parents alert about
Should
Wilson's disease.
parents be alert, as in what all should they look for? Yeah.
I think he's asking parents should be alert that they would have Wilson's or not. I think he's asking like that.
So, Mr. Vinod,
we can unmute him and ask him what is he's asking.
So maybe you can answer both the questions.
Okay. Okay. So if daughter has Wilson disease, and if you are thinking that parent can have Wilson disease, then it is very unlikely that Wilson's usually present up to the age of 30 years and very rarely 40 years. So most likely parents are carriers, and then daughter has Wilson's disease. But yes, the siblings, your other children, you will have the chances. And what are the things which parents should be alert? So it depends on what is your daughter presentation. Is it hepatic Wilson or neurological Wilson, and age of presentation. So if your daughter is having hepatic Wilson, you should give proper chelation therapy and look for the signs which shows that the therapy is not working, which shows abdominal distension, any GI bleed, and she is getting anemic, and she is getting cachexic, not gaining properly height and weight. So you should be more alerted. If she is having neurological Wilsons, then look for his writing, his school behavior. If they are worsening, then there are the chances that she is not getting proper chelation. And other than that, what your doctor says, to follow regular checkups, regular routine 24-hour copper testing as advised by you 6 monthly or as advised by your doctor.
Lovely. Thank you, Dr. Nida. Also, in the middle of this webinar, I would also like to thank Mr. Sahil, who is a patient and a warrior of Wilson's disease, who is very active, and he's taken such a initiatives to support everyone. So Dr. Nida, Dr. Arora and I are very thankful to him to start this initiative for helping others. And so neurological Wilson is what Sahil is really suffering from. And so neurological Wilson is a little varied in diagnosis as well. So a lot of children who come to us present with change in their handwriting, the rhesus sarcoidonicus, choreoathetosis, that is abnormal movement, some cognitive impairment, seizures, hyperreflexia, some urinary problems, and autonomic dysfunctions also. There are 4 distinct diagnostic categories based on patients' major neurological findings could be. So there is involvement of the basal ganglia, that is the extrapyramidal symptoms, which could be decrease in the movements that they could do earlier. So there is also a group when there are the movements that were present now become abnormal. There could be decrease in the movement or abnormal movement. There could be increase in the tone. There could be tightness that is present also. So if you're suffering or your relatives are suffering from any of this, they should be also. So this is something I'm sure everyone with any knowledge of Wilson's disease is aware of. This is the Kehr-Fisher ring that is present. It is very commonly in 90% cases of neurological Wilson's present, but still it needs an expert eye to diagnose this KF ring. It will not cause any problem in your vision. It is just to help us in diagnosis of Wilson's disease. So it is observed in 90% of individuals with symptomatic Wilson's disease, also almost invariably present in those with neurological Wilson's, and no longer considered pathognomic of Wilson's disease unless it is accompanied by neurological Wilson's. So it is formed by deposition of corpus in the Descemet's membrane in the cornea. So this is a patient of Wilson's, and basically here we can see that there is abnormal movements of the jaw here that is present, and that's why he has a face like that. So, so Vinod is asking, once patient is out of the neurological issues, can these issues recur even if the patient's taking all medicines properly? So, Dr. Arora, would you like to answer that, or?
You see, what happens is it depends on the component and the causative factor for injury to the brain. After all, there is no direct relationship between your urinary copper, serum copper, and deposition into the tissues. They do not go hand in hand. It is still possible that if you're not compliant with your medication or if you're not compliant with your diet, you may end up having deposition of the copper in the brain in spite of the fact that the serum copper is normal. So that should not give you a false sense of satisfaction that you have been doing a good job. Stick to the basics of diet, continue your medication. More often than not, you'll be on the right track. But knowing very well that the relationship between the blood level and the tissue copper store is far more complicated and dynamic rather than having a linear blood test and the tissue level. They usually do not go hand in hand. So be on, this is the maximum you can do. Stick to the diet, stick to the medication, have a regular checkup. And more often than not, the person will not be aggravated. If they are getting aggravated, that means there is something wrong down the track, either in terms of your diet, medication, proper dosing, timing of the, and other factors.
Okay, thank you. So this is that. Now, except the neurological and the hepatic presentation, do we have other presentations as well? So we do have important manifestations like hematological manifestation. They present, Wilson's disease patient will have a hemoglobin which is much lesser than their peers due to the hemolysis, that is the breakdown of blood that is occurring, and that supplementation should also be done. They will have some bone related issues, so a good supplementation of vitamin D, calcium is required. Then some cardiovascular issues can be present, so a routine ECG echo should be done. Renal, as we spoke about. So there can be a early onset cataract, so that cataract should also be evaluated annually. And for females with Wilson's disease, there can be some little problems with the periods also should be present. So now the staging I will leave, and so this will be the end of my talk. The rest, I guess, has already been discussed. Thank you so much everyone for your patient listening, and we, I think, do have one or two more questions, and with that, I would just invite Dr. Nida and Dr. Arora to take these questions, and so we are just reaching the end of the webinar as well with this. So one is about the diet of Wilson's disease. So I think I will also share a paper on the group about the copper diet. There is a copper reducing diet that is being going on that. And if Dr. Nida and Dr. Arora have something to say about the diet in Wilson's disease.
See, it preferably try to consume as much of the copper in the diet as little as possible. The reason is, even if you take small amount, it may give you a lot of trouble because it's not been excreted from the liver down into the tissues where it is supposed to be acting. But at times, because of the vagaries of a day-to-day routine, you're shifting to other places, your compliance with your mom and compliance with your diet, you may not be sticking it as religiously as one wishes. So Veronica is going to give you a paper and a newspaper cutting and maybe a PDF which gives you all details. You can go to the Google, look at the low copper containing diet. But suffice it to say, most of the resins and the dry fruits, they tend to contain the maximum amount of the copper. There has also been some attempts to not use copper vessels for drinking water, which may have enough of copper to give you the trouble. So if you go to the Google and take the PDF, I think if you follow the instruction, so that will be a big boon to your containment of the disease.
Okay, thank you so much. Dr. Nida, would you like to add anything or?
No, very well explained by Dr. Arora. So the same thing should be followed. Avoid copper vessels, which is used in many households still now, and they just forget about this, which I have many patients. And strictly follow the high copper diet, but you can have some.
You mean low
amount
copper
of
diet,
Don't
right?
go
Yeah.
for just go for copper content in that food, and they just don't roam around for this.
Yeah. So thank you so much. And I think it has been a very interactive session, and we come to the end of the session. And is there, if there is any question, now is the time to ask. So I think we have discussed most of the aspect of Wilson's disease today, and we have good hope for more targeted genetic therapies as well. And so thank you so much, Dr. Arora, for sparing time. We had so much to learn from you. Thank you, Dr. Nida, as well. And we hope we can do this in the future and maybe involve more doctors as well. So we intended to dedicate this to the patients today. And so I think there are some more questions here, but maybe due to the lack of time, Ishita, you can speak to me about the rare disease policy personally, right? So I will just share my email ID. We will all share our email IDs and we can get in touch about that. And any final messages from our doctors, or we can just now end the session. Sir?
Yeah, I think, Veronica, you've done a wonderful job for educating the people who are having the Wilson disease as to how to go about preventing the further damage to the brain and the liver. I think if we keep on spreading this type of message for other liver diseases, you should understand this Wilson's disease may also have concomitant other diseases like hepatitis B, hepatitis C, alcohol, or overeating, which if you tend to add up onto an underlying liver disease because of the Wilson's will produce a double whammy and will further accentuate the problem. So all of you should have vaccination for hepatitis A and B. Do not drink alcohol. Try to maintain your weight as per your BMI and try to avoid fast food. That will be big help to the liver, which is already struggling with the overload of the copper. So help the liver overcome the basic nuances of indiscreet use of alcohol and fat in day-to-day life. That will be my final message.
Thank you. Thank you so much, sir. And Dr. Nida?
Yeah, thank you, Dr. Veronica, for such a good session, good platform. And yeah, no, I know that doubts will not be over. They will continue have to have doubts. So let's answer again whenever they needed. Okay.
Yes. Yes. Thank you so much, everyone. My just final message would be that it is important for all of you to have a diagnosis that is correctly diagnosed as Wilson's. We have seen more often than not patients carrying the diagnosis of Wilson's disease for the longest time, but actually turning out to be something else. Just because we have a medicine for this disorder does not mean that it is only Wilson's. So be sure that you are suffering from this disease before taking lots and lots of drugs and not getting cured. So genetic testing is a must for every person who's diagnosed with Wilson's disease. It will help you to know your condition. It will help you to know which organ is more likely to be affected. It will help you to know that can this problem go to the next generation, and it will help you to prevent it. And the most important thing, it will help you in acquiring and taking and getting gene therapy when it is available. So gene therapy will only be available to you when you have a genetically confirmed diagnosis of Wilson's disease. And let's all get together, support each other, help each other, and fight this little problem of Wilson's disease. Thank you so much, Redcliffe Genetics, for this, and thank you everyone, all of you who joined today. I hope we could help you in clearing some of the doubts, but we're always there constantly for you. Thank you so much. Thank you, Dr. Nida, for joining.
Thank you, respected doctors, for taking out time from your busy schedule to be a part of this webinar. It was an extremely insightful session, ma'am, and it was loaded with a lot of information. With that said, respected doctors, I request your permission to end this webinar.
Yes, thank you so much. Thank you.
Thank you so much, ma'am.